as far as our results go, what I would highlight is we identified 160 patients. So 120 of them had pure urothelial carcinoma, and then 40% had urothelial carcinoma with some degree of squamous differentiation or histology. To break down further, what I would say, the 40 patients who had urothelial carcinoma with squamous histology, 10% of them had pure squamous histology, 20% had predominant squamous histology, and then 70% of patients had only a focal component of squamous differentiation present on their biopsy. When we compared baseline patient demographics and clinical characteristics at the time of metastatic diagnosis, we saw that patients with urothelial carcinoma with squamous histology tended to be slightly older. When we looked specifically at the time of initiation of an immune checkpoint inhibitor, we again saw that patients who had squamous histology were older than their pure urothelial carcinoma counterparts, but they also tended to be sicker or have possibly more advanced disease. They had lower hemoglobin level, lower baseline albumin levels. They also had a higher neutrophil to lymphocyte ratio. We didn't see any significant differences when we looked at patients at the time of initiation of enfortumab vedotin, but this was a much smaller subset of our cohort. As far as the results, so the first thing, as you mentioned, that we did see, and I would say perhaps unsurprising, is that looking at the time from initial metastatic diagnosis, patients with urothelial carcinoma that had some degree of squamous differentiation fared worse. They had an inferior overall survival. And what was interesting is that we saw that across patients who had predominant or pure squamous histology, but as well as patients who had just a component of focal squamous histology present. Then when we looked at specifically the time of immune checkpoint inhibitor initiation, we also observed, first of all, a trend towards lower objective response rate in patients who had squamous histology, as well as shorter median progression-free survival and overall survival, again, relative to their pure urothelial carcinoma counterparts. And similarly, when we looked at patients who started on enfortumab vedotin, there was a significantly lower objective response rate of only 17% for patients who had urothelial carcinoma with squamous histology compared to 70% in patients with pure urothelial carcinoma. We also saw shorter progression-free survival in these patients with enfortumab vedotin, and non-significant, but a difference with inferior overall survival as well in patients who had squamous histology. We went into this analysis suspecting that clinical outcomes would be different between the two histologic groups. And so what we wanted to get at was whether there were any differences at the molecular level, specifically genomic differences between the two histologic groups that maybe could start to explain or provide possible mechanism for the differences in outcomes that we could observe. So we looked at next generation sequencing, and that was present in a subset of patients. About 70% of patients had this done. Smaller subset of cases had tumor mutation burden performed as well, and PD-L1 expression. And that kind of reflects the evolving clinical practice around the use of these biomarkers, specifically for patients with bladder cancer that we treat with an immune checkpoint inhibitor. So the focus here was mostly on the genomic profile, and we looked at alterations that are present in 10% or more of cases. So we had about 17 involved genes, and a lot of these were the usual suspect for bladder cancer, including the TERT promoter gene, TP53, CDKN2A, CDKN2B. And then we looked at the prevalence of alterations in these genes across the two histologic subtypes. And as you said, we saw that tumors that had squamous differentiation were enriched, had a higher prevalence of alterations in CDKN2A, CDKN2B genes, in the PIK3CA gene, as well as MTAP, but had a relative paucity of alteration in the ERBB2 gene for that dictates expression of HER2. And the existing literature on this, I would say, is mixed. There have been some analysis, including a large study from Memorial Sloan Kettering that looked at genomic profile across pure versus variant histologies. which in that analysis did not see any significant differences in the genomic profile of urothelial carcinoma with squamous differentiation. Now, the metastatic status of these patients, of these cases, was not reported. We don't know the percentage of squamous differentiation these cases had. Other smaller analyses have reported some differences in the genomic profile of urothelial carcinoma, though different genes than the one we observed. So I'd say this is, this part of our analysis is definitely hypothesis generating. It's a smaller sample size, and it really needs to be validated in a larger cohort. But I think that may point towards possible mechanisms that could explain the differences that we observed. And I think as we start to develop targeted therapies for the treatment of patients with bladder cancer, I think it becomes even more important to really explore potential differences in the genomic profile between the two, between really all the different variant histologies that we encounter. In particular, what I'll highlight is, there is, I would say, a growing interest in the development of HER2-targeted therapies. So that includes various antibody-drug conjugate, including trastuzumab deruxtecan, and then disitamab vedotin. We actually have a clinical trial that's ongoing here at UCSF looking at this HER2-targeted antibody-drug conjugate. Now, what the factors that determine HER2 expression are vast and complicated, and it's not just alterations at the genomic level. But it'll definitely be interesting going forward to look at or to think about HER2 expression in patients with squamous histology. Our findings would indicate that these tumors may be less likely to have increased HER2 expression. And so, as we develop more of these targeted therapies, they may also be expected to have inferior outcomes to targeted therapies based on these differences that we observed at the genomic level.